slides. The slide with the handout list was last week's handouts for Part 2. You got many more than 3 handouts for this webinar today, and hopefully you saw in both your email and in our chat box the tip to be sure to already have those handouts printed out and handy and next to you as part of helping you stay engaged in the webinar today, as well as just good learning theory. We're going to be getting you in and out of those handouts, and they're really meant to serve as a note-taking guide. You can write all over them because you have access to those electronic copies at any time, so that you can always print a clean one out again for yourself. So if you haven't already done so, I really encourage you to have those handouts handy, because a good bit of the content today is not on the slides. It's in the handouts, and we're going to be referring you to that. So just another quick tip to get those next to you. So let's go ahead and get started today. I wanted to start with an overarching headset that's a reminder here for our focus for Part 2 and Part 3, and that's this theme that prevention is more than just a discipline. It's a movement, but we need both. We need both the movement and the discipline. We need folks who are rallying together and saying that we need change, but we have to marry that with the science of prevention. A lot of questions came up in our last session when we talked about both the use of scare tactics and the use of personal stories or recovery panels. Those pieces can be such an important part of the movement when used appropriately, but with the science and the discipline of prevention tells us what audiences are those best for. And we're going to revisit that today in a little more depth as we go. So hopefully you were all with us for Part 2. And last week we had covered those lessons learned the hard way. We're going to use that as our jumping off point today to look at some key guiding principles in prevention and make sure that we're all grounded in a good approach to prevention. Some questions did come in after the Part 2 webinar, or that we didn't have a chance to get to last week in Part 2, and a lot of them did surround this question of where do personal stories fit in. We had folks with a lot of different kinds of, in a sense, speakers bureaus of local community folks who've been personally impacted by this issue or within their family, and who are happy to go out and tell their story to try to make a difference. And the question is, where does that then fit in if those stories aren't appropriate for a youth audience? We are going to revisit that after we get you some grounding and good science and what prevention says does work, and just kind of some headsets for that. So I'm going to do another thing like I did last time here, and we're going to stick a pin in that point, and we're going to come back to it here by the end of the webinar. So let's go ahead and shift to what does work in prevention, and I want to direct you to your handout that lists 8 different guiding principles for prevention, and that's one you're going to want to keep right by your side today, because we're going to be using this as our framework, and then for each of these principles we're going to go delve into a little more detail, and that's where some of the other handouts do come in. So the first guiding principle, of course, is that effective alcohol, tobacco, and other drug prevention efforts need to be evidence-based and do incorporate evidence-based principles. There's 2 ways to look at that, that maybe you're working with an actual curriculum, let's say for school-based prevention or a community-based approach, and there is a program that's already been found to work and you are replicating it. And maybe it's gotten what they call NREP, N-R-E-P-P, certification, National Registry of Effective Programs and Practices. And that means they actually even had a research done with a control group and found that the one that was exposed to their program, that it did work. So if you're replicating that, that's an evidence-based program. But you can also be using logic of theories and models and science of what works and creating your own approach, and that's where you're incorporating evidence-based principles. Basically, by doing one of those 2 things, we're grounding our efforts in something that's been shown to be effective and that's accountable, especially when we're using very often limited public dollars or donated dollars. We need to make those dollars stretch, so we don't want to reinvent a bad wheel by doing things that have been found not to work. So we need to always start with what we do know. This, of course, Principle 1 has been the basis of why we did this G.A.P webinar series, and it's real important to note that it's very hard in just 1 hour today to give you years of prevention science. It's very hard to summarize that in only 1 hour. So what we're going to do today is paint with a very broad brush and point you in some very important directions of where you would want to get more information. Let's go ahead and look at guiding principle number 2, and that does tell us that effective prevention efforts focus on risk reduction and or enhancing protective factors or building assets. And we're going to understand that language here a little better by referring to our next handout. But while we're approaching this whole risk protective way of looking at things, we need to note that communities have to target multiple risk and protective factors. You can't be singularly focused. These issues are complex, particularly alcohol and other drug-related issues and other societal problems. They didn't happen overnight. There isn't a single cause. We have to be multi-focused in our efforts, more comprehensive, and we need to prioritize what risk and protective factors are in play in our community. And therefore, we need localized research and data and information, not just theories, right? So it's very important to have local information. We're going to talk about that today as we go. But before we dig into that piece of it, let's go ahead and look at risk and protective factor framework, which is the predominant model in prevention today. And I want to point to that by first helping you take a look at your handout. And it is called the Risk and Protective Factor Framework, and it's a nice table with quite a few rows and columns there. In the second column, you see it headed risk factors, and you see a list of various risk factors. And then in the next column, they're tied to different, and this is focused specific to adolescents, adolescent problem behaviors, including substance abuse, but some other things that can also be related problems, and which of those risk factors, per all the research to date, have been found to correlate, often happen in conjunction with those different problem behaviors such as substance abuse. Then the next column does show some protective factors as you scan down for those. And then we've got this headset of the social development model that we're not going to really cover today, but is a nice visual there for you. That would be something to definitely get some more information about, but that's kind of an overall headset paradigm to build from the bottom up of how we get to healthy behavior on all kinds of different issues. So as you scan through those different, let's say, risk factors first, just looking at that column, and you look at the check marks for substance abuse, look at where they are. Like if you look in the domain that's at the community level versus they get into smaller domains such as family, school, peer groups, and the actual within the individual. If we start in that community domain at the top, the one concern I always have with the risk protective model is that not all of these do weigh equally. Some of them are more closely tied to the actual alcohol and drug choice than others. So while there may be a community problem where there's a lot of transition and not a lot of stability within the community population, there's a lot of mobility, it's a more transient community, that makes it hard for there to be a community identity and for someone to feel, a part of their community. That's not going to be as closely connected in causation to an alcohol and drug problem as would be the availability of alcohol and other drugs. If they're easy to get in my community, that's going to be much more tightly tied. So I always encourage folks to look at this model not only with their local conditions in mind, but with a common sense eye of what is tied more closely to an alcohol and other drug choice. So if we look again at the family domain, the next section down, certainly if my family has a lot of conflict or family management problems, that could create a whole host of problems for kids in that family. But more tightly tied to the alcohol and drug issue would be if I have a family history of alcohol and other drug use, abuse, or dependency. So again, and the parental attitudes, do my parents not only role model it, but maybe even encourage it or accept it easily, or they provide that safe place for me and my friends to drink because they don't want us out driving, so they act as social hosts. That's going to be a lot more connected to a problem for that child than would be that my family has conflict now and again, or even often. You can have families in a lot of conflict where there's no alcohol and drug problems. But having favorable attitudes is going to be more closely tied to it. So I wanted to point to this as a framework where this could be a whole hour or even a 6-hour day to really dig into this research and what this all means and how do you use it on the local level. It really helps underscore the key point that I always like to make is that prevention is more complex than anyone wants it to be. And as we look at how do you use this model, there are a couple options. If you think about it, how the slide is, that the arrows are the risks and the shield is the protective factors. One option is to decrease the number of arrows or remove the arrows or risk factors that are involved in our target population or in our community. The other option is to build bigger and stronger shields, which is building and enhancing protective factors. So when we take a look at our approach using this model, that's our goal. We're either going to decrease risk factors or enhance or build the protective factors in our community. I would encourage you to set that handout aside, but keep it handy because we're going to come back and look at that as our framework for prevention today that most people are very grounded in. So let's go ahead and continue for now with our guiding principles. Guiding principle number 3 is that effective prevention efforts ensure that the needs of all the highest risk populations are being met. Therefore, we need to direct all our strategies and our services across all 3 target populations. And in prevention, we have adopted the terms from the Institute of Medicine framework. It's the IOM, Institute of Medicine framework of universal, selected, and indicated. And your next handout should have an arc on it that's divided like into pie slices. And we're going to take a look at that arc. But first I want to define universal, selected, and indicated. And those definitions are on that handout for you. So if we're looking at a universal population, that's just a general group. Anyone who showed up that day at that community meeting, in that classroom, at that workplace employee education session. So it's targeting everyone, a general group, regardless of level of risk. So there's going to be a mixed group. You may even have people in there, honestly, who are not appropriate for prevention, who need treatment, but you don't know that. You don't know what you don't know. It's a general, universal audience. So we approach that, that it's before an indication of a problem. We're going to be universal in our approach, knowing that through being there that day, some folks may come up after who have needs greater than that, and it's our responsibility to be able to refer people when it's outside our scope of care. So a universal audience is any general audience. The selected population is that next ring in our target population bullseye, and that's when we're targeting persons or groups that can be identified as at risk. And that can connect back to our risk protective model. For example, under that family domain, we know also with individuals some constitutional factors there at the bottom of that grid speak to, some biological risks. That if I am a child of an alcoholic or addict, just with one parent or one grandparent with alcohol or drug issues, I have a 4 times greater risk for developing my own problem. And that's a biological risk factor. So even if I were adopted and raised in a family with no alcohol or drug issues, but my biological family history has addiction just in one parent or grandparent, I still have a 4 times greater risk for developing my own. That's a known risk group, children of alcoholics or addicts. There may be other risk groups such as students in trouble at school. We know that there's research on youth that are more wired to be sensation seekers or risk takers, and that applies to adults as well. It doesn't end when we're youth. So when we look at prevention across the lifespan, we need to think about all of these types of at-risk groups, and that would be a selected population. So we might be doing a more targeted prevention service for a selected population. That can include things like mentoring programs for kids that have been found to be at risk, doing some employee assistance outreach to employees who have been shown to show some risk. Maybe children of alcoholics, whether it's for adult children of alcoholics or kids when they're younger. So that would be our selected populations. For an indicated population, now we're down in this more targeted part of the bullseye where this can get tough to know where does prevention end and treatment begin. When does each scope of practice fit in, especially if we're a certified prevention specialist? When would we be starting to operate outside our scope of practice? So this can get a little more gray for folks, and we need to be as clear as we can, especially if we have a credential, that we are targeting individuals here from a prevention point of view that are identified as experiencing some problem behaviors related to alcohol and other drugs in order to prevent the progression of the problem to addiction. So it's meant to address the earliest indications of a problem. Maybe even they got a DUI. Not everyone who goes to a driver intervention program is addicted. So some driver intervention programs have people that are certified in prevention as well as treatment, right? This does not include doing a clinical assessment. That's outside the scope of practice for a certified prevention specialist, regardless of what state you're in, right? That's outside the scope of prevention. We can do screening, but this isn't only about screening. We might be doing more of an intensive support group for, let's say, young people who got caught on school grounds with cigarettes, in possession of cigarettes. violating school policy or smoking on the school campus, or with a group of college students who self-identified around an alcohol or drug issue, and it's not clear yet how far progressed they are. Maybe they got referred through the athletic policy at the college or the high school, or from the workplace, and they're being referred to our program, and the program is there to help them take a look at their use and help self-identify, is it use, is it abuse, can it still be turned around with more intensive prevention, has it progressed to potentially addiction, and do we need to get an assessment to see if that's true? And then prevention is not the one to do that. We're facilitating the referral for an assessment, and then if they need treatment, they proceed on to the rest of the continuum of care. And that should be helpful as you look at that arch across the top of your handout, because that arch really helps show the entire continuum of care. Now, it starts with promotion as part of prevention, where we're promoting prevention as a lifestyle. We're promoting healthy choices. When we get into more preventing problems, then you get into that universal, selected, or indicated targeted services. Then we got a pretty clear line here where we go into treatment, that case identification is now where we get into an assessment. That's the scope of treatment, and then the actual treatment, and then recovery and maintenance, and aftercare for recovery support is all that maintenance, the last two sections. So as we look at that entire continuum of care, we can see where we all fit. Now, in our last webinar, we had used a more simplified breakdown of this that was more global, where we just spoke about PETA, prevention, intervention, treatment, and aftercare. So I wanted to show you how that PETA, more simplified way of looking at the continuum of care, fits, and this arc really helps divide up each step along the continuum of care and how it all fits together a little bit better, depending on where someone is with the progression of their use and what services we should be doing to target that. So hopefully that was helpful for looking at the scope of prevention and where it begins and ends. And we have a lot of folks on the line that may be with coalitions, or maybe with what we call a family engagement advocacy group, where you're working with families who've been affected by this issue, and there's both a support component to what you do and maybe an advocacy or prevention strategy piece to what you do. And there can be coalitions or family engagement groups that are also trying to advocate for more treatment or recovery support services. But again, this webinar is focusing more on the P, the first half of this arc, and when we're focused on prevention, what's good prevention? So let's bring it back to our guiding principles. And those guiding principles, number 4, is that effective prevention efforts are focused across the lifespan and not just on youth. If you think about the reality of, even kids and underage drinking, where are kids getting the alcohol? Where are they getting the idea for it? If there isn't an adult somewhere in that chain, or an adult system, or the adult setting the norms of the culture. We have to, even when preventing youth use, address adult use and adult attitudes. But we also have the reality that the majority of substance abuse happens over the age of 18. The largest use group of all substances is 18 to 30, and especially that 18 to 25, and they're not all in college. How do we approach those adults that are not yet addicted, are still a target for prevention services, and not just only focus on kids? So we talked about that last time, and there's certainly things as you look across this lifespan all the way to our sweet little lady here in our graphic, about her appropriate use of her meds and whether or not to mix those meds with other meds or with alcohol or with some over-the-counter things, and being educated and appropriate with her use of medications as well as her own use of alcohol and other drugs. And as our 1960s baby boomers age, they're bringing some other cultural norms in with them that we have not previously had to deal with in quite the same level of saturation within our elderly population, where a lot more marijuana use has come with that population than we saw in previous generations. So we certainly have things that we need to address when we look across the lifespan. Guiding principle number 5 is that effective prevention efforts focus on the environment and not just on individuals. And I want to take us back to look at that risk protective framework and be reminded of how they divide these risks and protective factors into those 5 different domains. They really list 4, but that peer and individual one, I wish they'd redo that and make it a clear differentiation. And I think there's a lot more they could be listing that we have found in other research around school risk factors and protective factors and peer group. So it's not a perfect framework, but it is the strongest one we have that's very research-based and that there is the most predominant use of right now. So even in this model, it really looks at this kind of this nice visual you have of this concentric circles, again, of the individual building all the way out to the community, because the community does impact individual beliefs, attitudes, knowledge, and therefore behaviors. So we've got to be looking across. So as we think about that, prevention approaches can have an individual focus. We're not saying let go of that. You need to have individual as well as environmental. And when they have that individual focus, regardless of the age we're working with, everyone needs in our society to really have clear understanding and knowledge for healthy beliefs and attitudes about alcohol and other drugs, that they know what the risks are. There's accurate perceived risk. They've internalized a belief that they're worth more than that. They know what to do so it won't happen to them. They're invested in keeping themselves healthy, so they know how to follow through and make a good decision, and they have the skills to follow that through anytime, anywhere, in any situation, so that we have healthy individual behaviors. So this is where much of the prevention traditionally has been focused over the years, especially when it comes to youth-based prevention, especially within school-based prevention. So many of our alcohol and other drug prevention efforts are those curriculums that happen that ideally are evidence-based, like life skills or Project Alert, and they get to a lot of this kinds of really solid stuff. When it comes to that reality, notice some things are changing, especially for some of you community folks that aren't in a school or are newer to prevention. That school-based prevention money has been drying up for years. And so you may think your schools have a solid prevention curriculum in place. It's worth asking. That's where we as coalitions and outside community family groups can really bring that movement of prevention back into the schools and say, what are the barriers? What do we need to do to ensure our kids are getting what they need as a core base, while we also then, in a second, we'll deal with the environmental factors and influences within our community. But if they don't have this good base, and so I think that's something we can all be advocating more for and try to be problem solvers of how do we deal with these barriers and get creative so that our kids do get what they need to succeed. The other piece of this is that someone asked a question in the last session, and I want to bring it up, and this was from Kristen French. I don't know if she's on the line with us today, but Kristen wanted to know if it's still appropriate to present the negative risks associated with alcohol use through information dissemination or education as a strategy, because we had talked about scare tactics don't work. So what about the negative risks, like kids who start drinking before age 15 are 3 times more likely to develop an alcohol-related disease as an adult than versus those who wait? And she wanted to say if that's framed within a comprehensive strategic prevention approach, and it's one prong on the fork, so to speak, is it still appropriate to share that kind of information? And absolutely it is. We still need to be able to educate people about the negative consequences, as long as we're not doing that in a fear arousal only mode, and assuming that if we arouse this fear, and it's a strong enough fear, the fear alone is going to keep them from engaging in the behavior. Sometimes fear is a natural consequence of telling the truth. But the research shows if you arouse some fear or some level of concern, it's okay as long as you give people a way to resolve it and that you don't arouse too much, that the fear becomes the overriding message and it's like we're fear-mongering. So when fear is a natural consequence of telling the truth, and I don't even like to use the word fear, that we're ingraining in people a perception of risk, a perception of harm, that this can be harmful. People do need to know there's harms here, but we also need to focus on the benefits of therefore not doing it and what to do, this whole decision-making and skill development piece. So the message alone, and the more fear-based it is, that's when we get into scare tactics. I hope that's clarifying for folks. So it can't be that standalone message and relying on fear to make the difference alone. Right? So we have to be very careful with that. I'm hoping that's clarifying and helpful. So as we look at individual approaches, and they're not all just education, there's a lot of skill development and other things here, that's not going to alone do it. And for a lot of years, that's mostly all prevention was doing. And if you get, let's say, even a kid in a school that's got the best resources in the world and the best evidence-based curriculum, and then they have to walk out of that school and walk home, and let's say it's a half-mile walk, And in that half mile, they've got to pass 3 carryouts, and their signs are filled with signs like 99 cents for a 24-ounce beer, 4 Loco on sale. They're going by a bar. They're going by other signage or billboards. You know, what other messages? What are they seeing on the street? Are people dealing? Is someone offering them something? What else is going on in their community? And what happens when they get home? What's being role modeled there? So we also need to certainly address the environmental factors that surround any individual of any age. And this is where we get into our 4 components of environmental. How could we slice and dice? What are those environmental influences? And we have adopted here at Drug Free Action Alliance the CAMP model, and that is another handout you have. You see CAMP going down vertically, and it talks about the community norms, access and availability, media messages, and policy and enforcement. So when we look at that, I just want to point out some things on this handout. Under community norms, that second bullet, norms can encourage high-risk alcohol and other drug use, or it can discourage it. Or you could turn that around. Norms, we can help promote positive and healthy norms that encourage healthy behaviors, and that's the norm, right? And those community norms can be for an individual, such as parents. Maybe there's a norm in our community that parents provide a safe place for kids to drink because they don't want them out driving, so they serve as a social host very often, and that's just seen as, as long as they're not out on the roads, it's okay, and it's well-intentioned, but it's very misunderstood. So we have that community norm. Maybe we have a system with a norm, though, that we've got some sellers or servers that sell to overly intoxicated people of any age, or that we've got sellers that are selling to underage, and that's maybe our norm within our business community, and we need to say, no, we want good corporate citizens in our community, and that's the community norm we want, and we really want you to be in compliance with the law and help, protect our children. Another cool thing in the community norm section is this reality versus perception piece and social norming. That is a really phenomenal area to learn more about. It's called social norming. You may want to make a note. So very often the minority's been setting the norm, particularly for our kids, and alcohol, and now these days more and more marijuana, that everybody's doing it. And the research in almost every community shows that's not true. So if we can really help spread the word that most kids are not doing this, and that's a protective way of approaching this, is that we're enhancing the perception and the understanding of the reality that folks, more folks or more kids than we realize are not doing it. Let's hold up the good example so that there's that positive peer pressure. Under access and availability, that's certainly really tied in the research very strongly to alcohol and other drugs, and the more we can lock down the access and the availability, the less use and the less problems we see. And that can be everything from what's our tax base. We can price it out of kids' pockets. The higher the price is on these products that are legal. What kind of access do people have to meds? Those kinds of things. Media messages. Media messages can be used to send clear messages supporting healthy choices, but we also know that media messages can help really support unhealthy choices. And advertising is the first place people go, but there's so many other ways for us to look at the media. If we're in the individual level, we go back and create media literacy, and that may be a term you've not heard before and you want to learn more about. But on the community side, we can be using the media to our advantage, even on a very small budget, and doing media advocacy to maybe change a policy or to have a social marketing campaign to promote a healthy choice. And I'm going to give you some examples of these in just a second. Policy and enforcement also comes in, and that's really not just policy and enforcement at the law level in a community. That can be in smaller shared environments, such as what is our athletic team policy, what is our school policy, what's our college or dorm policy, what's our workplace policy. Is it being enforced consistently? Do we have supervisors in our workplace who look the other way when they're assigned someone maybe high on the job and they're not addressing the issue in a proactive way, and instead they wait for an accident to happen, which is not good for anybody? So when we're looking at policy and enforcement, there's a lot of ways to look at policy and that not just be laws. This can also be systems change across sectors. So I want to give you an example with one thing. If you look up at the camp at the top and see how these can play together. So if you've got parents in your community that are acting as a social host, you can use Parents Who Host Lose the Most, Don't Be a Party to Teenage Drinking. It's an established program. It's one of our programs here at Drug Free Action Alliance. It's in all 50 states and many countries now. And that's a media message that is intended to make change in all three other areas here, trying to change the norm, that it's unsafe, it's unhealthy, it's unacceptable in our community that parents are acting as social hosts. Here in Ohio, it's legal. If you want to give alcohol to your own kid, great, but you don't have the right to make that decision for my family. So we're trying to change that community norm. This is not okay. That will therefore limit access and availability, the less parents who are doing it. And if your community doesn't have it, you could be working on a social host ordinance or even a state law. But you also have to work with law enforcement about dealing with barriers to enforcing that law. So there's one example of a program or approach that crosses all four of these environmental factors, and that's a really tried and true strategy. And you could do the same thing with medications and access and availability. People aren't securing and locking up their meds, or they're not disposing of old meds. That's an access and availability issue that's also maybe a community norm within an elderly population of a certain generation where you don't throw anything away. And then you've got to deal with some policy and enforcement and maybe getting some systems change about where can we get lock boxes, and then use media messages to promote the importance of securing, monitoring, and disposing appropriately of your meds and getting people using those options. So you can see how all four of these can really work together in a real strong way. So at this point, I'd just like to sum up on that last strategy, and that is that we need both the individual prevention approaches and the environmental prevention approaches to come together in order to have a comprehensive approach for real change. So this is the time when I'd like to take a break here in our guiding principles to take any questions that may have come. So I'm going to turn it back over to Derek and see if we had any questions come in.
And Allison, at this point, we have not had any questions. If you do have a question, you can enter your question in the question section of the control panel. And I still see no questions at this time.
Okay, great. Well, then let's go ahead and proceed here with guiding principle number 6, and that is that the effective prevention efforts are most likely to result in effectiveness when we are more collaborative in our community and in our community planning. Now, it doesn't only mean coalition work, but if you've got a family support group who's been affected by this issue and they're out there kind of working on their own, doing what they think is going to work, and you got a coalition over here doing their thing and a prevention agency over here, and then law enforcement doing their thing without maybe knowing what else is going on or who's trying what or what the research says, and then you've got this business community approach, and whether that's drug-free workplace or responsible beverage sales and service, and it's all just happening hodgepodge without there being kind of a community mind share of what's going on in our community, what's the actual problem, what can we be doing or what are people already doing, where are the gaps, what do we need to do so we don't duplicate our efforts, and how can we, if you're old enough, you'll remember the Wonder Twin Powers Activate moment, from Saturday morning cartoons. How do we, bring that together in order to more effectively maximize all of our efforts by knowing what the left hand knows what the right hand's doing, and we all have our piece of the puzzle, and there's a comprehensive plan for that. So helpful. Here in Ohio, we have family children first councils at the county level that help coordinate across county systems. A lot of coalitions evolve out of that. Coalition tables are helpful for that, but coalitions aren't just about networking and not duplicating. It's also about trying to synergize and having multiple strategies across multiple sections, and we all own our piece of the puzzle. So we have to involve the community level folks in both planning and implementation. And so we are a strong proponent here at Drug Free Action Alliance for coalitions for that purpose. And as we look at engaging in multiple strategies across multiple sectors, I want to look at those two phrases. Let's start with multiple strategies, and I want to refer you to your handout that comes from the Prevention Institute. It is the spectrum of prevention, and you'll see this grid that has from the bottom to the top 6 levels of prevention. And it starts, again, if you think of that inner core with the individual, and builds all the way out to societal level, community level things. So if we start with the individual, we of course do need to strengthen individual knowledge and skills so that people have the ability to follow through with preventing injury, safety issues, health, including addiction, and that they're making healthy choices and life is good. Next level up is if you go outside that individual to promoting community education where we're reaching groups of people, Maybe that's a group of parents or all the teachers in that school or all those human resources folks within our business community through our Chamber of Commerce, where we're reaching into groups of people with information and resources to promote health and safety, and that helps trickle then into individual level as well. We also at level 3 would be educating providers, maybe folks who actually are getting training to transmit this information to others. And again, that can be more than just information in level 2, but now we're actually training them to do something and transmit skill development knowledge to others. So we're increasing our capacity in our community to deal with this issue in meaningful ways by getting more people engaged in a trained way in prevention strategies. Level 4 is then when we are fostering those coalitions and networks so that we're not duplicating each other's efforts, that we know where our gaps are, we fill them the best we can, and we're maximizing each piece of the puzzle that we're all doing so all hands are on deck, and they're on the same deck, and there's, direction for the ship, and we know where we're trying to go as a community. Level 5 is when we actually work to change organizational practices. Maybe there's new regulations or changing norms within a system. Maybe it's about memorandums of understanding, that more of our businesses have an employee assistance program and a drug-free workplace program, and they refer, when folks are showing signs of a problem, they refer for an assessment and do help versus fire instead of just firing that person and let them go try to find another job and passing the problem on when we've already got an identified problem. Maybe the organizational practices are around our law enforcement and our business community and those compliance checks for alcohol sales and service. Organizational practices can be within our schools. What is our, and this could bring in level 6 too with policy, what is our athletic team policy? And are we following it through, right? And then up at the larger level, those policy efforts all the way up to laws. But keep in mind, again, policy isn't just law. It can be in a smaller shared environment within a community. So we work from across all 6 of these and have multiple strategies across all these levels of prevention. And across multiple sectors, this is happening. So there's work in all 6 levels of prevention happening with the youth in our community, but also with the media. So the media is looking at how they frame stories around alcohol and other drugs. Great example here in Ohio. We had a college group in a college town where a fraternity and sorority, brother-sister sororities and such, went to a very important underground railroad museum. And in this place, they had some kind of reception, and everyone got so wasted they were actually throwing up into exhibits. It was horrifying what all went down, and the local paper referred to it as shenanigans. And we called them on that. So, and we have that relationship with media to be able to do that. So how do we work with media across those 6 strategies or levels of prevention? Our schools, our senior citizens, our social services, law enforcement, across every single one of these sectors. And to put those 2 together, we want to really foster engagement across all of these community sectors and across all 6 levels of the spectrum of prevention. And by doing that, we will now have comprehensive prevention efforts. Prevention's a lot more than going into a group of kids and saying, don't do drugs, drugs are bad. It's a complex issue that takes complex solutions, that is not a one-shot deal of a piece of information. We need to be a lot more comprehensive, strategic, and planful in changing our community norms and systems and policies to support health promotion and prevention. So hopefully that's a helpful visual there of how we put those 2 together. All right, for guiding principle number 7, effective prevention efforts are part of a comprehensive strategic community plan, which is data-driven. And I want to put that together with guiding principle number 8, that we also need to be doing checks to make sure that what we're doing is working, and not just working at the program level, but it's working at the population level. And that may be someone else's job in our agency, our coalition, our effort, or in our community, but we need to see how what we're doing is impacting the community. To best do Principle 7 and 8 is having this planful and measured, is what we're doing working. Highly recommend getting grounded in the Center for Substance Abuse Prevention, which is our federal department for prevention through Health and Human Services. they promote the strategic prevention framework. And I don't want you to get overwhelmed by this graphic. This graphic really just represents a most common sense logical planning model. So think about this in maybe something, let's unhook from communities and alcohol and other drugs. Let's just look at something a lot of us have dealt with at some time in our life, is some kind of health or fitness goal. So if I want to lose 50 pounds, how do I know 50 pounds? Well, I have to assess, what is my weight now? What's my ideal weight for my height? Let's assess what are contributing factors to why I'm overweight. Let's assess in my community, what all do I have access to make changes? So I have to be able to have some accurate measures of what my problem is, as well as then look at my capacity for making change. Do I have access to a place to work out? Do I have access to healthy foods? Do I have access to knowledge and understanding about what will work for me? And then I have to make a plan. Then I need to implement it and see it through, and then I'm going to have to check, is it working or not? And I'm checking that, is it working or not, against my baseline data. I started out at 150 pounds. What do I weigh now, right? So as we're taking a look at all of that, we need to then ground it in sustainability and cultural competence. Now, to break that out a little bit more, you do have a handout on understanding the strategic prevention framework that you see this flower at the top, and it breaks down each of these steps in a lot more detail. Okay, and I'm just going to throw some thoughts up here. So when it comes to alcohol and other drugs in our community, we have to profile what's actually going on in our community. So for example, we're all hearing so much about prescription drugs and opiates throughout Ohio, especially right now. But we have a lot of communities where it's still not really their primary issue. Their data says very clearly it's still alcohol and marijuana. But their community is up in arms about opiates and prescription. So they have a readiness issue where the community is ready to address prescription and opiate. How can we use that community readiness to open the door to talk about the wider spectrum of substance abuse and how alcohol and marijuana play into the problem, right? So our community has its attention woken up on something. We don't ignore that just because our data says something else is the actual problem or bigger problem. It's how does this all play together? So we have to know that data in order to be able to get our community ready to deal with all of it, right? So we need to know what's going on, including what's already in place in the way of resources and gaps, and then look at our capacity to make change, to deal with our identified problems. So how are we going to be able to mobilize or build capacity? Does our core group need more training? Do we need to know better what works and what doesn't? Do we need to know better what's already going on so that we don't duplicate the service? How much money do we have? How much volunteer effort do we have? What resources can be brought to bear on this? And now we can make a prioritized plan that's logical, that's going to meet our community where it's at with a known need versus an assumed need, and just hopping on a bandwagon, right? Because we're dealing with data we actually have from our community. And then we implement that using evidence-based prevention activities. So part of our planning has to be building in what works or what will work here. And that means we may, back to capacity, need more training in that in order to make a good plan and know how to implement it well, and what's our piece of that puzzle, and then we have to monitor it. Is it working? How do we sustain and improve these efforts and replace any that may fail? Now the key is here that you need all of these 5 steps, and of course within all 5 we need to address how long can we sustain this effort, what do we need to sustain it, and are we in every step of this being culturally competent with various cultural groups in our community. Culture means more than race. That can be a whole other webinar, is what is cultural competence. But the key is a lot of communities have like for example with the opiate crisis in Ohio, and people hear the word crisis or epidemic and they want to jump on this bandwagon and they want to jump straight to let's do something, and it's not a planful approach. Prevention is both a movement and a discipline. The discipline isn't just knowing the science, it's knowing my community and knowing what's going on. And if I don't have the ability to go find that out, who does? Is there someone at the health department who's got a profile of what's really happening in our community? What alcohol and drug agencies exist in my community that maybe have been gathering data? And I can say, can we sit down together and help me look at what's, as a community concerned neighbor, how do I fit into this? With the efforts that maybe myself and some of my neighbors or other people who've been affected by this issue want to be part of making change, where do we fit into it, right? And what can we do that's grounded in good prevention? And because, not every group has the capacity to do all 5 of these steps, and that's where coalition and working together can really be helpful. So with that planning piece that is so important, the purple step there is so important, I want to just very briefly talk about a logic model, and in a really broad stroke way. So the Substance Abuse Mental Health Services Administration provides this community logic model that I just want to break down into 3 simple things. These little words at the bottom are mine. The boxes are theirs. They talk about you have to identify your substance abuse or related problem. What's happening in our community? So it's data-driven of what's happening here versus what the media tells us is happening everywhere. What does my community look like with this issue? What are our priorities and problems? Why is it happening here? How does this tie to these risk protective factors that you saw in that handout? Which ones seem to be more in play in our community? How could I check out that assumption? Is there any other information, a focus group, meetings with parents, meetings with our business leaders? How do we find out why this may be happening in this target population in our community? And then what can we do about it? What does prevention science say are some good efforts, and how do we be comprehensive in what we do? Who's doing what already, and what's my piece of the puzzle for me or for my group? So to look at that another way, CADCA, which is I never can remember everything that they stand for. It's blanking for me, but it's the Center for Alcohol and Drug Coalitions of America, something like that. CADCA is really an excellent resource for coalitions nationwide. And they provide this way of looking at, they take those 3 boxes into these 3, where you get your problem statement, that's based on your local data. You look at your root causes, those risk protective factors, why is it happening? And what does research say about what are root causes for this that could connect? And then let's play that out more about what does that look like here in our community. I'm going to give you an example of that in just a second, but there's a 4th box that they add, and that is what strategies are you going to use to address each of your local conditions. And that's your next handout, which are those 7 community change strategies. Again, broad brush today. That alone could be 1 to 6 hour workshop on really breaking down those strategies, from providing information, enhancing skills, and providing support. Those first 3 certainly can be individual level strategies, but they also could be systems. How do you get a system to buy in that they need to be part of the solution? You may need to provide them information and get them to understand this really is a problem in your community. So maybe you meet with parents and you're trying to get parents to wake up to the issue, or to law enforcement about here's what we want you to prioritize is, good business practices with our sellers and servers, for example. What skills do they need? How do we provide that support? The last 4, 5, 6, and 7 are much more environmental, for sure, in their approach for strategies, and being as comprehensive as we can across all 7 of these community change strategies. If you put all that together, that 4 boxes now provide such a great logic model, right, of telling us what to do. So I want to just show you a quick sample of just the first 3 boxes from one community here in Ohio. Now this is very general. The youth prescription abuse they found was a problem in their community. They would have that laid out with data, like what their percentage rate was, right, and then put it into an objective that's measurable about in how much time do they want to decrease it by what percent. But we're just going to show you this in a more general way, that the problem is youth prescription abuse. Some root causes that seem to connect in their community from risk and protective factor model was that they did have a high level of availability. Kids said it was really easy to get that stuff, and there were some real favorable attitudes. And what that looked like on their local level was that they found that there were a lot of teens that thought, well, since it's legal, it's safe. And that was an attitude belief that it's a safe high. And how were they getting it? Well, they found that it's been widely prescribed, that doctors were just, throwing a pill at everything in their community really easily, and that there was an awful lot of unsecured old meds out there and a lot of sharing of meds that was going on. And so they found that there were some common behaviors happening like that in their community, and that is what they decided that they were going to address their 7 change strategies toward. And then there's a whole other handout I could show you of what they said they were going to do with each of those. But as you can see, time is of the essence. So before we get back into what the personal stories and how they connect, I want to see if there's any questions, Derek, that have come in about our 8 guiding principles for prevention.
Yes, we do have a question from
Great.
Jessica, and Jessica would like to know, you discussed the spectrum of prevention and the 7 community change strategies. How do the two differentiate from one another, and how do they work together along the perspective, or the prevention spectrum?
Great. Well, let's see if we can come up with a quick example for that. So when we're looking at the 7 community change strategies, for example, if we're looking at how do you get it at level 6, let's start there on this level, the spectrum about getting legislators to maybe buy in that a policy is needed, you're going to need to provide information to them to demonstrate that this is a problem for them to have buy-in that anything needs to be done at all, right? And then once you've got that, you better be sure ready to know which of these strategies. Do you need a policy that's going to change access or that's going to increase barriers? Right? So, for example, pill mills are a big problem. So we have legislation. We had to wake up our legislators and go, this is a problem, and we need a policy now that gets rid of this access issue, and we need to shut down these pill mills. Maybe it's about changing consequences and incentives. So let's work with the medical board for these doctors that are over-prescribing or that are being, doing all this, participating in doctor shopping. So we need to change consequences and incentives maybe from a system and not just from a legal perspective. So that would be at spectrum level 5, where we're changing some organizational practices for maybe the medical board. Or here in Ohio, we've got a system that docs and pharmacies can use for tracking who got what medicine and how much, and when somebody's engaging in doctor shopping, it can become known more quickly, but we don't have enough doctors and pharmacists and dentists using that system. So that would be changing an organizational practice. Level 5 is the level of prevention we're addressing, but we maybe need to provide more information and enhance skills. Maybe those doctors, pharmacists, and dentists in those 7 change strategies using number 1 and 2 don't know enough about that system and don't know how to use it. So maybe we need to get someone who's doing some training for them in how to use it and finding out what their barriers are to using it so that we can change in number 4 strategies, decrease their barriers to using that system. I hope those concrete examples kind of helped you see how these could play together. Were there any other questions, Derek?
Those are the only questions that we have at this time.
Okay, great. Let's go ahead then, because I know that we really want to get into where do these personal stories fit in, which is something that came in so strongly last time. So first off, framing back again to our big picture here, that prevention is both a movement and a discipline. The personal story angle, we found that the research says that that's not as meaningful and effective and can even backfire when we have those stories told in an audience with youth, particularly knowing that we have at-risk youth, the selected population, and an indicated population, folks that are maybe further even along. But even just having at-risk youth that are known sensation seekers or risk takers, and we may not even know which ones they are, that can actually backfire. So it's not as appropriate to do those recovery panels or family personal stories with kids. But when we look at the movement part of this and you look across the spectrum of prevention, boy, personal stories really help key systems and movers and shakers in our community across that colorful pie of all the sectors to say this is a problem in our community and we need change. So if we're going to advocate for a policy, people need buy-in. They want that personal story from. So especially the upper level spectrums where you see the blue arrows, those personal stories can be very, very beneficial. And even when we're educating providers, now I want you to think that maybe as a parent group. And there's a caution here. Presenting that information to parents or to teachers or to school administrators so that they take seriously this issue and see that this is really happening in the community and someone's willing to tell their own story, to put a personal face on it, can help spur people to action. It's a way to engage a sector in your community, right, or to wake them up. But then you got to tell them what to do, right, to prevent it, and invite them to be part of a change effort and have and here's what you can do, call to action for them. So it's not just telling the story. The caution on this is the more people you do this with and tell those personal stories and they're moved by it as adults, they don't know what you know now, which is that it doesn't work well with kids and can actually backfire. You're going to get more and more people saying, boy, you tell that story so well and our kids need to hear that so they know not to do this. Or, boy, that recovery person who may be, 19 or 20 and is now, 4 or 5 years clean, and they're telling that story of their teen use and now that they're clean, and, boy, they're an inspiration. That's an adult headset about what people would get from them telling that story. Remember what we talked about last time? That's not necessarily what the kids are going to get from hearing that story. So that means you're going to get even more pressure to tell the personal story more often in front of kids. So we need to really give you some headsets. I think for those of you, and I know we got a couple people who either are folks who often can go out and tell their own story, or who work with folks who do in kind of a speakers bureau kind of thing. So those stories must be tied to a goal. It's never a standalone strategy, and I want you to think about the spectrum of prevention. Who am I talking to and for what purpose? Is the message I'm giving appropriate for this audience? How do I tailor my message? Is it a group of kids, in which case, no, it's probably not appropriate. Why am I speaking? What's the goal? What's the call to action? Are we trying to get a policy change? Am I trying to increase community readiness? Am I at a town hall meeting with a general universal group of adults in our community who are concerned about this issue, and I'm the wake-up call? And then how does my story fit into what we're trying to invite them to do, or to what action do we want them to take as a result? And am I tying this to that? Or is someone else who's part of the podium or the moment of the presentation tying it to a call to action? This means that whether we're working with families who've been affected by this issue, or I'm one of those family members and we're part of this support group who also goes out and tells their story, we need to feel comfortable ourselves, or if I work with those folks, I need to help them get comfortable with saying no, and that it's okay to say no. My story is not the best fit for that. Let me refer you to another resource here in our community that would be a better fit for talking with your 8th grade health class, or for doing that assembly with your kids. And so having more and more being tied into what prevention efforts are going on in your community, so you can refer people to the more appropriate service rather than saying yes. And I'll tell you, I'm real sensitive to the reality, because we work with these families a lot here in Ohio, that a lot of them are still dealing with their own grief, and their concern is, if I say no, what if then something happens to one of those kids, and I possibly could have saved them if I'd gone out? And that's an easy thing to get fished into, that we need to unhook from that sense of over-responsibility. And still remember the hard reality that if telling that story with that inappropriate audience actually increases use for one of those at-risk kids, now we've harmed one versus helped one. So it's a tough, tough thing, but we've got to be more clear about who am I talking to, why am I speaking, and what's the call to action, how does it fit in to larger efforts, and what am I asking them to do with this information. So I want to flip back to that spectrum. Think about 6, 5, 4, even 3, potentially with some caution. What kinds of things could my story do in helping to promote community change by being willing to be the public face and the personal story for this issue? Okay, so let's go ahead and see if there's any questions that result from, sorry about that, I hit the wrong slide number. I'm going to just flash some tips up here while Derek sees if there's some more questions that came in.
Yes, Alice, we do have a few questions.
Okay.
The first question is, would it be good for someone who has had experience in drug abuse, etc., talking to the kids to speak about their negative choices and to spin it on making positive choices?
I'll tell you, it would take an awful lot for me to feel comfortable working with that person to be sure that the message that is intended is what got received. There's so much research that says that that's not what ends up happening, especially for our more at-risk kids. I would really more encourage folks to unhook from recovery panels and cautionary tales as a strategy to be used with youth. Think instead about putting up in front drug-free kids who are facing the same day-to-day challenges, and they're making those healthy choices, and we're social norming that most people don't do this, and here's how I follow through with that choice, and here's the benefits I get from being drug-free. That would be a more positive message to put up there.
And this question was also from Carl, and I think that it was a follow-up question that I think you just answered, but it says, what about concentrating on challenging those kids who are making good choices to use their own peer pressure?
Yeah, perfect. That you know, is something that we're doing right now with the Ohio Youth-Led Prevention Network, that we are the drug-free majority. Definitely check out that Facebook page and be, you know, part of that movement of having drug-free kids stand up proudly and say, we are the majority, right? So that the minority will quit setting the norm. That's that social norming approach we talked about. Yeah, that's a very powerful approach. And the more we can hold that up, that's more of a protective factor approach and focusing on the positive and saying, don't do drugs, drugs are bad, and here's all the horrible things that can happen if you do it. We need to balance promotion of a healthy message with, yeah, there are negative things that can happen, and make sure they know there's perceived risk, but let's try to balance out more that we're focusing on all the good things that can happen when you make positive choices and use positive peer pressure and the power of peer pressure in a positive way. Other questions, Derek?
I have two more questions that are very similar. Both Jessica and Matthew have asked pretty much the same question, and the question is, can you send a list of research or articles that emphasize why personal stories aren't a good idea for youth but might be for others? They have strong community organizations that really like the personal stories.
Yeah, and it's tough. It's a tough uphill battle to get folks who are really hooked into that as a strategy. And so, yeah, being able to show them that research, I understand. That is something we're working on. We're creating a fact sheet on scare tactics and a summary of the research of why they don't work. And we're also going to be creating one of those that's more at that lay community level on why the personal panel, recovery panel, cautionary tale kind of panel doesn't work and what the research is saying. So that is something we're in the midst of developing. And we'll definitely keep you guys and your emails handy in order to get that out to you. Certainly, I don't know how quickly it'll be available because we're working with some interns to do, finish doing some of that research for us so that it's all in a nice encapsulated base. So it's coming. It is coming.
And then an additional question around that would be, could you also send resources on what does work with students?
And I'll tell you, I'm going to I can't because as what this webinar was trying to do for today is say prevention, there isn't a one-shot deal I can tell you that's going to work. It needs to be part of a planned process, what's going on in your community, and be a planned approach. I pointed to in CAMP and the risk protective models, things that you may want to address. I would encourage anyone locally who wants to be part of effective prevention efforts to find those certified prevention specialists in your community to see what's already going on and how you can be part of that or what your piece of the puzzle is. I can't just send an email that summarizes 20, 30, 40 years of prevention research and say, here's what will work in your community. I don't know what's going on in your community. So it's not as simple as that. There's not a simple answer like that. I'm so sorry. There just isn't. Get connected with prevention folks in your community.
And are you familiar with the research? Jessica asked this question. She recently heard that non-drug using kids telling a drug using kid not to use drugs will increase the use of drug use within the drug using.
Can you say that again, Derek? I didn't follow.
If someone who doesn't use drugs, a adolescent who doesn't use drugs, talk to someone who is using drugs and telling them not to use drugs, that will result in actually an increase of the drug using child.
I have not. Are they saying there's research that says that?
Jessica thought that there was.
Jessica, if you know of that, definitely send it my way. I have not seen research to that effect. I'd like to know about that if that is out there.
And then Kristen recommended.
But keep in mind, too, that drug-using youth is not a prevention target. So if we identify someone who is using, they need further services. They're outside the scope of prevention. We need to get them into an assessment and get them into the help that they need. A drug-free kid or a drug-free adult saying don't do drugs, drugs are bad, isn't going to stop someone who's already addicted. There's a lot more going on if addiction is present.
And then the only other question, or a comment from Kristen regarding the effective prevention was a recommendation to check out NREP to see what they see as promising practices and effective prevention programming.
Absolutely. Thank you, Kristen, for that reminder. Yeah, if you guys didn't jot down NREP when I mentioned it before, that's something to definitely go do some surfing. And again, if you yourself are not, a prevention agency-based person, And if you're new to the field, you need to get hooked up with other folks in your community who've been in the field longer and really see what's going on in your community and what's already been being done, and keep growing in your knowledge. For those folks that are more community-based, find who is doing organized, funded prevention in your community and get tied in to what they're doing. Any other questions, Eric?
That's all that we have at this time.
All right, that sounds great. So some quick reminders for everybody. Let's actually jump to our reminders. This webinar has been recorded and will be available on our Member Center, limited to our SPECA members and our Solace Network members here in Ohio. So that will be available via our Member Center to those folks. Certificates will be emailed to you in a PDF format within the next 30 days, but we first will need you to complete your evaluation, and an email will go out this afternoon with a link to a SurveyMonkey evaluation. The evaluation has to be completed before we'll get you a certificate. And if you signed in as a group or signed up for group viewing, if you did not get that sign-in sheet, it was sent with the confirmation email. You need to print that out, have everybody sign it before they leave, and that needs to be submitted to us for everybody in your group to get credit as well. So thank you very much for your time. If you have other questions, please feel free to still submit them or shoot us an email, and we'll do our best to get those answered to you. Sorry we went over a little again. Appreciate your time today.